Hello. So, sir, it's 3. Now, when we are live to the audience, we can start this meeting. Over to you, sir.
Good evening, everyone. Myself, Dr. Donavali Lokesai, Medical Affairs Department, MAC US. And I would like to welcome one and all for today's meeting. As we all know, diabetes poses huge burden on India. Did you know 1 out of 7 diabetes across the world is an Indian? Which India stands second place in terms of diabetes prevalence, and which is one of the major risk factors for microvascular as well as macrovascular complications. And nowadays, the focus of treatment also shifting from controlling glucose itself to overall controlling the risk factors, monitoring the glucose. And we have to stay abreast on current therapy and also molecules is very necessary in current scenario. With this, I would like to welcome Dr. B.K. Singh. Sir is a senior consultant physician from the Jharkhand, has rich clinical experience of 32 years. Sir's special interest includes cardiometabolics as our chairperson for today's meeting. And also, I would like to invite, next slide. Dr. D.K. Jaha as our esteemed speaker for the day. Sir is also a consultant physician from Jharkhand and also associate professor in the Palamu Medical College. To throw more light on Vildagliptin, more to explain. Sir, it's my pleasure to introduce both of you, sir. Over to you.
Yes, thank you. Thank you very much for your words. So, Dr. D.K. Jha has been my old colleague at Medical College at Dhanbad, and he's a very hardworking, very intelligent, very studious, and research-oriented person. I know him personally, and it is a pleasure to welcome him to speak on such an important topic like Vildagliptin. What is the next move? What is more? So I invite. Yes. So I request Dr. D.K. Jha to start his presentation on Vildagliptin. Yes, Dr. D.K. Jha, please.
Good evening, sir. And now,
Yes, Dr. D.K. Jha.
Yes. The slide is not visible on the screen. Hello, Dr. Lokesh.
Sir, I'm correct. Himanshu, can I share the slides to you?
Yes, you can share it to me, or else you can also share it from your end.
Okay. Sir, I will share from my end. Sir. Is it okay for you?
Yes, yes.
May I help, Lokesh, sir? You're not audible, sir.
Am I audible? Can you listen me?
Yes, sir. B.K. Singh, sir, you're audible. I'm asking to Lokesh, sir. He's not audible. Okay. The slide is there. It is coming.
Sir, no slides are visible.
It is loading. Okay, it's visible. So can you please make it slideshow mode?
Yes, next slide.
Okay, perfect, sir. Thank you.
Sir, over to you, sir.
Yes, Dr. Jha. I think now you can start.
Yes, sir. Good evening. Now, India accounts for 1 in 7 of the diabetic worldwide. It is known the one of the leading metabolic disorder today in the world is diabetes. Now, our country is the second highest country with diabetes mellitus in course of prevalence. It is estimated till 21, it is about 74.2 million diabetics in our country. It is now the capital of diabetes worldwide. The key of the treatment is to control the diabetes and keep it under control to prevent future complications. And long-term glycemic control is essential to improve outcomes. 1% decrease in HbA1c translates to 43% lower decrease in amputation or fatal decrease about 19% in cataract extraction, about 16% reduction in the heart failure, and 14% in the fatal myocardial infarction. The awareness of it, how hyperglycemia causes these macro and microvascular complications in the long term. The third, the decrease in creatine effect, increased lipolysis, increased glucose reabsorption, decreased glucose uptake, increased neurotransmitter dysfunction, increased hepatic glucose production, increased glucose secretion by cells in the pancreas, and impaired insulin secretion. Ultimately, all these factors contribute to this increase in blood glucose, that is increased hyperglycemia. Next. Now, the DPPI-4, how it acts, how it's lowered the blood glucose level. When the food taken, it absorbed in intestine, then the pancreas releases active GLP-1. Now, by beta cells, glucose-dependent insulin secretion, and the alpha cell glucagon suppression. Glucose-dependent insulin secretion, it increases glucagon by muscle, glucose uptake by muscles and the liver. Glucagon suppression, this decreases hepatic release of glucose, and DPP4, the active GLP, and DPP4 there it activates GLP-1, that is glucagon-like peptide 1. Now, the DPP4 inhibitors, how they act? They lowers the glucose reabsorption by more than 94%, which is resolved by filtrate in the epithelial cells of the renal tubules. Remainder of the glucose reserved in the small segment of second and proximal convoluted tubule. The glucose then in the interstitial port via the glucose transporter 2 and GLT-1 in the second and third piece. Next. Now, how SGLT2 inhibitors, they increase glucose, that is hyperglycemia, leading to glucosuria. What there is in steatoid deposition in liver, formation of ketone body, reduced blood pressure, angiotensin and endothelin depression, glucosuria or super reduction in weight loss, increased lipolysis, gluconeogenesis. All are inhibited by dependent on SGLT2, and these all mechanisms are ultimately inhibited by SGLT2 inhibitors, thus leading to increase in hyperfiltration, intraglomerular pressure, albuminuria, thus preventing the long-term renal damage. Now, the other benefits of SGLT2 and the decrease age-mediated effects, decrease in age-raised signaling, increase body mass, decrease adipose tissue deposition and inflammation, decrease leptin production, skin sodium content, and liver steatosis. These ultimately leading to ketone body production and metabolism, reduced myocardial sodium hydrogen exchange, reduced stable heart rate, more glycemic control, improved endothelial function, decreased in vascular stiffness, decreased systemic blood pressure. This will, in macrovascular effect, reduced in plasma volume, increased hematocrit and red blood cell mass, decreased plasma uric acid level. This LTL also causes natriuresis, osmotic diuresis, increased glomerular afferent arterial vasoconstriction, and decreased intraglomerular hyperfiltration, and increased glycosuria, and thus leading to reduced albuminuria, thus protecting the renal damage. Next. This slide shows how the pharmacological treatment of hypoglycemia in adults with type 2. The first line therapy was dependent on comorbidity, patient-centered treatment factors, including cost and access consideration, and management needs, and generally induces metformin and comprehensive lifestyle modification. The AFPT indication for high-risk heart failure and patients with CKD, the recommended independently of baseline HbA1c and individualized HbA1c target for metformin users as or indications of high risk GLP-1 with proven cardiovascular benefit, SGLT2 with proven cardiovascular disease benefit, HbA1c above treatment or patients on GLP-1 receptor and consider improving SGLT2 inhibitors with proven cardiovascular disease benefit and vice versa in T2DM. In Hyo, SGLT2 inhibitor proven benefit in this population. In patients with CKD or renal dysfunction with diabetes, this SGLT2 causes CKD and albuminuria reduction. CKD without albuminuria also increased GFR, preferably SGLT2 with primary evidence of reducing CKD progression, or the SGLT with evidence of reducing CKD progression in COVIDs, or GLP-1 receptor agonist with proven CVD cardiovascular diseases benefits in SGLT2 not tolerated or contraindicated. For patients with CKD, estimated GFR less than 60 without albuminuria or recurrence, the following to decrease cardiovascular risk. Yeah, either you start with GLP-1 receptor agonist with proven cardiovascular disease benefit, or SGLT2 with proven cardiovascular disease benefit, ultimately leading to, if HbA1c is above target for patients on SG2 alone or considered in GLP-1 receptor agonist or vice versa. The improved potent agents that provide adequate efficacy to achieve and maintain glycemic goals. Higher glycemic efficacy therapy like GLP-1 receptor agonist, insulin combination approach, as shown in table, considered additional comorbidities, patient-centered treatment factors, and management needed in choice of therapy as below. Minimize hypoglycemia. No inherent risk of hypoglycemia in these two agents, DPP-4, GLP-1, SGLT2 receptor agonist, or sulfonylurea based in or insulin. The other consideration during treatment is to reduce episodes of hypoglycemia, that is to minimize hypoglycemia. Now, low inherent risk of hypoglycemia in these agents like DPP-4 inhibitors, GLP-1 and SGLT2 and thiazolidine, or sulfonylurea or basal insulin, consider agents with lower risk of hypoglycemia. If HbA1c above target, then incorporate additional agents based on comorbidities, patient-centered treatment factors, and management needs. Second aim is minimize weight gain or promote weight loss. Here, the choice is preferably GLP-1 receptor agonist with good efficacy for weight loss or SGLT2 inhibitor. If target of HbA1c is above, then for patients on a GLP-1 receptor agonist, consider incorporating SGLT2 and vice versa. If GLP-1 receptors are not tolerated or not indicated, consider DPP-4, which is weight neutral, and thus incorporate additional agents based on comorbidities, patient-centered treatment factors, and management needs. Now, the next factor is cost. Consider cost and accessibility. Available in generic or at lower cost. Certain insulin considered available at the lowest acquisition level, sulfonylurea and thiazolidine. If HbA1c above target, then incorporate additional agents based on comorbidities, patient-centered treatment, other factors, and management needed. These graph the linear plot of mean plasma concentration of Vildagliptin versus actual time for here. Mean comparative line. Linear plot of Vildagliptin plasma concentration. Here we see the reduction, the actual time for test product of Vildagliptin and Vildagliptin PD. Here, the similar mean whether it is PD or in once in modified dose, once daily dose. The reduction is same. Weighted average DP inhibition in 0.25 after administration of test product Vildagliptin Vildagliptin. In alone, Vildagliptin sustained release, it is 85.28, whether and in BD dose, it is 86.79%. Next. Vildagliptin, it is more convenient because it is once daily, not recommended in if creatinine clearance is less than 50 ml per minute, can be taken with or without. Next, Vildagliptin glycemic variability. The glycemic variability is also less in with this DP4 Vildagliptin as is seen in 16-week baseline study. Standard. Next. The Vildagliptin also lowers albuminuria in patients with T2DM and with hypertension independent of glycemic control. The rate of albuminuria control and in Vildagliptin, whether we say that is much reduction in the rate of albuminuria. Then the cardiovascular meta-analysis of long-term effect of Vildagliptin on cardiovascular and heart failure safety. 14 studies are there which has gone phase 3 as well as phase 4 and more than 17,000 patients included. Vildagliptin, the average age is 57% and the study indicates that about 50% patients with high cardiovascular risk, 18% had a history of cardiovascular disease and more than 40% with renal impairment. The primary outcome shows composite of mass, non-fatal MI, non-fatal stroke, and cardiovascular death. The secondary outcome shows there is non-fatal MI, non-fatal stroke, cardiovascular disease, and also reduction of heart failure events. Next. The meta-analysis of Vildagliptin, there is no increased risk of MACE. There is Vildagliptin compared to other. It indicates there is no increase in risk of other factors. It is The different studies has no major effect on left ventricular ejection fraction. There is no adverse effect on myocardial infarction, on stroke, or overall cardiovascular disease. Effect on left ventricular ejection fraction in heart failure patients. The randomized trial Vildagliptin versus placebo. Placebo is patients included between 18 to 85 years of age with T2DM and heart failure with reduced ejection fraction. The study done for 1 year. The primary endpoint treatment change from baseline in left ventricular ejection fraction compared with placebo. Vildagliptin has no major effect on left ventricular ejection fractions. Next. The SGLT2, cardiovascular death, and the renal composition. All the cumulative incidence does not show much better reduction in dapagliflozin in cardiac as well as in renal effects. Rationale for combination. What is the rationale? What is benefit of this combination? That is vildagliptin as well as dapagliflozin. Next. Reason. The hypoglycemia, how it occurs? There is increased gluconeogenesis, decreased insulin secretion, decreased glucose uptake by muscles, decreased incretin effect in the bowel, increased leading to neurotransmitter dysfunction, increased glucose reabsorption, alpha cell increased glucagon secretion, and increased lipolysis. These all factors in combination ultimately leading to hyperglycemia. So ultimate effect, how to control is block these factors by one or more ways. So the combination of SGLT inhibitors and DP4. Next. The SGLT2 inhibitors, insulin independent glucose excretion, so no increase in glucagon, no increase in fatty glucose output. In Vilda, the DPP4 inhibitors act on alpha cell, thus reducing the glucagon, and thus reducing the hepatic glucose output. If combined together, the vildagliptin will take glucagon surge that occurs due to SGLT2 treatment. Thus, if they are combined, the SGLT2 acting on kidney and pancreas, increased glucosuria, less glucotoxicity, indirect pancreatic effect, there is increased beta cell sensitivity and increased glucagon. DPPI4, which counteracts this effect, that is dual pancreatic effect, increased insulin secretion and decreases the glucagon secretion. And on bowels, there is increase in incretin, which is controlled by GLP-1, thus leading to reduction in weight as well as blood pressure and reducing the hyperglycemia, that is the pleiotropic effect, and thus weight loss. Now the question is, does prescribing a drug twice daily impact compliance? Impact of reducing dosing frequency or on adherence to oral therapy at literature review and meta-analysis. Across acute and chronic disease states, reducing dose frequency from multiple dosing to once daily dosing may improve adherence to therapies among patients. Improving adherence may result in subsequent decreases in healthcare costs. Both are to be given once daily. So
Sir, thank you, sir. Thank you so much for enriching our knowledge as well as for sharing your clinical paths, which enriched our knowledge as well as audience knowledge. Sir, we got few questions from the audience as well. I will read out the question, sir. How do you place the combination of SGLT2 and DPP4 in your clinical practice? What are the advantages you note on combining the same?
Because it takes care of both. Causes not only control of blood sugar as well as other than glucose level, it also causes reduction of weight as well as renal and cardiovascular risk factors. So it is better placed and better tolerated as well.
Sir, we have received one more question, sir. DPP4 inhibitors has shown studies on improvement of time in range and reduction in glycemic variability. How does this matters in your clinical practice, sir?
In clinical practice, the matter is how to control the blood sugar level of the patient. So it is a once daily dose, better compliance is there, no side effect is there, and also protective on renal function.
Sir, how would you choose among the DPP4 inhibitors in your clinical practice to confer the clinical benefits to your patients?
We choose if they should not be given metformin due to intolerance or any other factor. Then these are the agent of choice.
Okay, sir. Sir, Vildagliptin 100 SR. Kindly share your clinical experience with same.
Yes, 100 gliptin, the effect is same. Either you give it twice or give you once. If it is sustained release, then it is 24-hour glycemic control. But the compliance is better because the patient not forget the second dose and he is better compliant with when the dose is of taking a single pill in place of 2 or 3 pills.
Thank you so much, sir. Sir, what is your final take-home message for the audience, sir?
The take-home message for hyperglycemia, not treat the glucose alone, but also protect the long-term complications, particularly the renal as well as cardiovascular effects, which is met by these two agents also.
Sir, finally, it's so happy to meet you both of guys, sir. Dr. B.K. Singh as well as Dr. D.K. Shah, sir. We thank our esteemed speaker, Dr. D.K. Shah, for sharing your wonderful medical insurance shared by. We also thank our chairperson, Dr. B.K. Singh, sir, for
Thank you very much.
being and thank you so much, sir. Soon we will meet in the future, sir. If if I come to the Jharkhand.
Thank you.
Okay, thank you very much.
Thank you, sir. Last but not least, we thank our technological partner for smooth streaming of this video, Himanshu. Thank you all.
Yeah, thank you. Thank you very much, sir. And with your permission, shall I close this meeting, sir?
We can end this.
Yeah, thank you very much. So from here, I'm ending this meeting. Thank you.
Yeah.